Okay, welcome everyone. I think we're going to go ahead and get started, and I know folks will continue to join us throughout the next 2 hours. So on behalf of NYU Langone Health, I'd like to welcome everyone to today's town hall on the COVID-19 vaccine. My name is Nadia Islam. I'm an associate professor at NYU in the Department of Population Health, and I have the privilege of working with community health workers and community-based organizations every day. So I'm particularly delighted to be a part of this event. We really organized today's session in response to calls from frontline agencies and community health workers to better understand the science and distribution of current vaccine efforts. All of you in the audience are often the first to have the privilege of working with community members around healthcare needs today. So I'm particularly delighted. A little bit of background noise if others can mute. Thank you. So you're often the first to interact with community members, and you really are purveyors of trusted information. So we're really thrilled to have this opportunity today to support your efforts in disseminating accurate, timely, and culturally appropriate information to our communities. Today's webinar is jointly co-sponsored by our NYU Community Health Worker Research and Resource Center in partnership with the NYU Vaccine Center and our city's health department. The CHWRRC, or Research and Resource Center, as many of you know, is housed within our Department of Population Health and supported by our institution's community service plan. It was launched in 2018 to really create an organized approach to bring together our collective CHW-related knowledge and expertise to strengthen our existing programs, to build new programs, and really to build community capacity and leadership and support this very critical model. So again, welcome to the many CHWs and community partners that are in the audience. And we'd also like to just extend a special welcome to 10 new community health workers and resident navigators that have just been hired by NYU just this week, who will be working to increase COVID-19 testing among NYCHA residents as part of a national RADx Up initiative. So on behalf of NYU and the many community health worker communities assembled here, we want to wish you all success in your important work. We can go to the next slide. I just want to go over briefly a few housekeeping rules in our new virtual world. I'm sure you're all very familiar with these, but we put them in place to make sure this could be a success and everyone can participate equally. So for this webinar, everyone is on mute. We really very much want you to interact and to ask questions. So please do not hesitate to post questions throughout. We just ask that you use the Q&A function. So the Q&A function is at the bottom of your screen, kind of in the middle of the screen. We'll have time to answer as many questions as we can during the Q&A portion. The chat box is open, so please do, I see all of you, many of you have taken advantage of this already, but please do chat with each other. It's a space for posting comments and also sharing resources. Today's webinar will be recorded, and slides and recording will be made available at a later date. And just a quick note that we're going to ask a few questions at the end to kind of assess how we did and to understand if this was helpful to you. We hope it will be. So please be sure to fill out those evaluation questions at the end. Next slide, please. So this is our agenda for today. We are so very lucky to have two leading experts on the topic of the science of vaccines and the efforts to distribute vaccines across the city. Dr. Mark Mulligan from NYU and Dr. Olusimbo Ige from the New York City Department of Health and Mental Hygiene. I'm not going to fully introduce them here. Our moderator will be doing that in a few moments. Next slide. So, I know it's difficult in these virtual platforms to interact, but we do want to start today's session with really hearing from you and understanding what you're hearing from community members. So this is a question that each of you can answer by either scanning the code that you see on the screen, or I believe Harmony has put a link in the chat that you can click on directly. So if you could just take 1 minute to answer this question. When speaking with community members, what is the most common reason people say they are hesitant to get vaccinated? So we will give everyone 1 minute to either scan the code and answer the question or click on the link. And you'll see that responses are starting to pop up. So we see a lot of common responses around many community members are scared about side effects. There are trust issues. There's questions of safety, how quickly the vaccine was developed, distrust of the government as well as healthcare agencies, a lack of information. Great, thank you. So I think I know that responses are still coming in, but I think that this paints a picture of what we understand is happening in communities, and I think what comes across to me is that this is a very multifaceted issue. There's not just one reason that community members may be hesitant. And a lot of the reasons are rooted in history and rooted in a long and sort of systems of care as well. So we will certainly, I know our speakers will certainly be directly addressing some of these issues around particularly side effects, the safety of the vaccine, how to better disseminate information, and also how to mitigate some of that distrust. Great. So there's one more question that I think will automatically pop up on your phone if you use the QR code, or I think you can go to the link again. So we wanted to get your insights on this question. When vaccines become widely available, what do you think we can do to make vaccines more accessible to the communities you serve? So this is really an area where all of you are the experts. I think you know best what our communities need to make care more accessible. So we'd love to hear from you what would help in that effort. Great, so we can see many responses popping up. Walk-in, I love that. I think, you know, it really speaks to making the vaccine process as easy and as accessible as possible for our communities. But I think there's many themes like that: easier scheduling, neighborhood accessibility, more appointments, using vans, partnering with churches and other community organizations doing vaccines directly there, going door to door, using credible messengers, so important and really speaks to your role in the audience. Great. So thank you for sharing. I hope this was useful for all of you to see as well. And we're certainly going to be speaking about these issues during the next 2 hours. So now I am thrilled to pass the webinar on to Ms. Ivette Cabrera, who is a community health worker here at NYU. Ms. Cabrera was born and raised in Brooklyn by her Ecuadorian immigrant parents, and she began at NYU Langone Brooklyn Hospital as a community health worker in the emergency room, and currently works as a CHW in the high-risk program at the Patient Navigation Center. She serves as a mediator and coordinator in helping patients navigate the healthcare system, as well as community resources. And we're really privileged that Ivette is a leader within our CHW Research and Resource Center as well. We're so happy to have her here today to moderate the session. So Ivette, I am going to pass it on to you.
Thank you so much, Nadia, for that lovely introduction. So Everybody, welcome to the COVID-19 Vaccine Town Hall for community health workers and community-based organizations. It's my pleasure to introduce our two speakers this afternoon who will help us address the questions that we are getting from the communities we are working with about COVID-19 vaccine safety and distribution in New York City. So our first speaker is Dr. Mark Mulligan. Dr. Mulligan is a director of the Division of Infectious Diseases and Immunology in the Department of Medicine and director of the NYU Langone Vaccine Center. He joined NYU Langone Health in 2018. He is a translational physician scientist who leads a research clinic and a research laboratory. He conducts vaccine clinical trials and clinical studies of emerging infections. He has studied HIV, Zika, Ebola, bird flu, and the 2009 pandemic influenza and other infections with public health impact. He is now studying the novel coronavirus. Dr. Mulligan's presentation will address COVID-19 vaccine safety and side effects. Our second speaker is Dr. Olusimbo Ige. Dr. Ige is Assistant Commissioner for Health Equity Capacity Building at the New York City Department of Health. She also serves as the Branch Director for COVID-19 Community Engagement. Through the vaccine community engagement work, she works to promote vaccine education to ensure equity and fairness in accessibility to all New Yorkers. Dr. Ige's presentation will address COVID-19 vaccine distribution and access in New York City. So Dr. Mulligan, take it away.
All right, thank you very much, Yvette, and hello to everyone in the audience and to my fellow panelists. Thank you very much, Dr. Islam and Dr. Ige. It's a pleasure to be on the virtual podium with you. Let me share my screen and we will get started. And Yvette, can you just confirm that you're able to see my screen?
Yes, I'm able to see it.
Great, thank you. Okay, so I want to thank Manor Ali, who is in our vaccine center and is our director for community education, for her making these wonderful slides that I'm about to share. I want to talk about understanding vaccines, about their safety, their side effects, how they're developed, what role we have had in them. And then I'm really pleased most of all to be here with a large group of community health workers because, as I'll say on my last slide, vaccines don't save lives, vaccinations do. We've got to get these vaccines out to communities, to individuals, to families, and it's only then that we can end the pandemic by achieving herd immunity, getting enough people protected via the vaccines that the virus has nowhere to go and we shut it down. So that's our goal. So we have NIH funding, the US government funding for our vaccine center. We're part of the national NIH funded network called the COVID-19 Prevention Network. And I'm really proud that at the Vaccine Center, which I have the privilege of directing, we're interested in people of all diversities, in children. And we have, because of that commitment in our work, we have established 5 vaccine research clinics around the city. 1 at Bellevue, 1 at the VA, and then 3 at NYU facilities, including Brooklyn, Long Island, and Midtown Manhattan. What is the mission of the Vaccine Center? Our mission is to protect and restore human health through innovative vaccine research. And as a clinical trials organization, we rely on community. Community is essential. We seek to engage community, to educate, and only after we've had a relationship and gained trust with community do we talk about the R word, recruitment into our clinical trials. And we do feel that we have to earn that participation, and then we invite community members to be a part of the solution, to participate in clinical trials. And then I think by extension, now that we have some vaccines available for the public after the emergency use authorization, EUA from FDA, community engagement in the vaccine rollout and uptake of the vaccine so that we can end COVID-19 in 2021. That's our goal. And community health workers, all of you, absolutely essential. And I'm thrilled. I just looked at the numbers, 295 of you listening in. But I, my staff, and all of you have work to do. What are those areas of work? Well, one is there's a lot of fear. And I saw that word on the word puzzle that we saw a minute ago. And so through education, to educating ourselves and then educating community members, we can offer strength and hope, a chance to fight for the future. And a vaccine certainly offers us hope. There's a time of uncertainty about this whole experience we're going through. Life has been turned on its ear for the last year, and we probably have another year to go. But we can offer optimism with a path forward through science, working together, and engaging in proven effective interventions. This shutdown, the social distancing, causes isolation, and this can have health consequences at many levels. And I think all of you know about that as community health workers. Not only psychologic, psychiatric, but also people not seeking care, routine care, follow-ups, or even not seeking care for new symptomatology because of concern about exposure to the virus. And so this isolation is actually damaging health. And finally, there's been a period of understandable, either ongoing or new mistrust in government, in science, because of some of the things that have happened in the last few years. And I just hope that today I can begin to rebuild trust. It is a time of rebuilding, a time of hope. We have fresh leadership across the country, and I think things are going to be much, much better. So let's get started. How does a vaccine work? So really, a vaccine trains the body to recognize and fight invaders. So if this is the virus, SARS-CoV-2, you've seen this on the television many times, a picture of the virus. After vaccination, when the body sees that, it sounds an alarm, rounds up the immune system troops, and then works to eliminate that virus from causing disease in the body. So that's what a vaccine does. One way to think of childhood vaccination is, you wouldn't send a group of New York City firefighters out to fight a fire in a skyscraper without an awful lot of training and preparation. Well, it's the same way, for example, with childhood vaccination. We wouldn't want to send our children into daycare or into schools where they'll be exposed to many, many viruses and bacteria for which we have effective, safe vaccines without training their immune systems to be prepared to fight off those disease-causing invaders. So that's what a vaccine does. It trains the body so that there's a memory of the virus in the immune system. And then in the future, down the road at some point, when we encounter the real virus out in the community, at work, on the subway, in the grocery store, the immune system that's been trained can recognize it and prevent it from causing disease. Another really important question that I get a lot is, can vaccines cause SARS-CoV-2 or COVID-19 infection or cause COVID-19 illness? And the answer is absolutely not. These vaccines are made in the laboratory, just a little piece that represents some component of the virus, but it's never the whole virus. This top cartoon of the bicycle, if the whole virus was the whole bicycle, the vaccine may only contain the front tire or the chain or the handlebars. It's never the whole thing. And so these single pieces cannot cause COVID-19 infection or disease. This bottom row shows you the whole virus, which is never in the vaccine, and then some of the components. For example, what's in both of our current EUA available vaccines, the spike protein, this red protein on the surface of the virus that is so important for the antibodies and T cells to fight against. That's what is in all of the vaccines really that I'll talk about today. So again, never the whole virus, just one piece, and you can't catch COVID from the vaccine. Really, really important. And there was never any whole virus there. We do have a variety of either EUA available vaccines or candidate vaccines that we are continuing to conduct clinical trials for. And what these vaccines do is train the immune system. So they provide a message or a signal to the body. And there are different vaccine platforms. The two that currently have EUA approval from the FDA, the Moderna and the Pfizer vaccines, are RNA vaccines. So what are they? So RNA you can think of as a message to the cell. It's called messenger RNA, or even better perhaps, a text message, or maybe a software instruction to the cell. The cell then makes that spike protein, nothing else, not the whole virus, and then the body's immune system recognizes that spike protein as something we probably should be concerned about. Let's make an immune response. And now we know, happily, that that cascade, starting with the message and then the protein, vaccine spike protein made in the body's cells, and then the immune response to that, we now know all of that results in 95% protection against COVID-19 disease. It's truly an amazing result. And those vaccines are very, very safe, as well as being highly effective. So that's the RNA platform. Another platform that I'll mention, because these are getting close. In fact, yesterday, one of these viral vector or adenovirus platforms, the Johnson & Johnson candidate vaccine, put in its application to the US FDA to be considered for an emergency use authorization. So that would be most likely, if the FDA grants that later this month, that'll become our third vaccine available for the public. I think everybody knows that demand is exceeding supply, and we need all of our candidate vaccines to be shown to be safe and effective. So we have enough vaccine for everybody in the US, and of course, very, very importantly, for the whole world. And we do have to have a global perspective with viral infections, pandemic viruses. And the reason is that as long as there is virus anywhere in the world, there's the risk of viral infection here in the US. In other words, all it would take is a international jet flight into the US, and now we've got the virus again, particularly if it might be one of the variant viruses, which may not respond as well to our vaccines. We're still learning about that. So we need all of our candidate vaccines, hopefully, to be shown to be safe and effective. And good news is that the Johnson & Johnson recombinant viral vector, it's a common cold virus. It doesn't multiply in the body. It contains just the DNA of the spike. That's the one piece. You then make RNA from the DNA, then you make protein, then the immune response. And now we know that it has a level of protection that may well be good enough for the FDA to provide the EUA. We'll see later this month. And that vaccine, like the RNA vaccines, appears to be safe. So those are the main candidates that I want to talk about today. There'll be others coming, like protein-based vaccines, which is sort of like the standard flu shot, where you don't provide RNA, you don't provide the DNA, you just provide the protein, along with an adjuvant, which is something that helps to strengthen the immune response that the body makes. So in that case, you would, instead of injecting RNA or the viral vector into the muscle of the upper arm, the deltoid muscle, that rounded part of your outer arm just below the shoulder where we get most of our shots, instead of injecting the message, the RNA or the DNA within the viral vector, you inject the protein directly, and then the body makes the immune response, and then hopefully we'll see protection with those protein vaccines. So those are some of the candidates, but I also wanted to talk about how we get to approval for a vaccine by the FDA. And it starts with the phase 1 trial. This is usually done in tens of people, from 20 to 100. And really we're asking, is the vaccine safe? Are there any serious side effects that would cause us not to proceed and further develop this vaccine? And then begin to learn about some of the routine side effects. Every medicine, every vaccine can have what I call expected vaccine reactions. And these are not a safety issue. These are the sore arms, maybe the chills or the fatigue we feel for a day with the vaccine. It usually starts within 12 to 14 hours of getting the vaccine and lasts for a day or so and then goes away, usually mild to moderate. And we'll talk more about this, but these are no cause for alarm. They're not a safety issue. In fact, I tell my patients, it's a good thing when you feel a bit of that, because it tells you your body is recognizing the vaccine and doing what it's supposed to. It's mounting an immune response. It thinks the vaccine, remember, is training the immune system. So the immune system thinks this could be something dangerous. I'm going to start an immune response. And so that when that happens, it's normal, natural response. And it's a good thing, really, to have a bit of that. Not everybody has it. It's usually half or fewer of people, a third of people, and usually mild to moderate. It's what we call vaccine tolerability, not a safety issue. These are expected vaccine reactions. So we begin to learn about those vaccine reactions, the side effects in the first phase. If everything looks good in phase 1, we go to phase 2, and instead of tens of study participants, we now have hundreds of trial participants. And we again are asking about the side effects, looking for any safety issues, but we start to ask more about the immune response. Do we see the antibodies, the B cells, the T cells that we think might be protective after vaccination? And can we get any early signal that we're actually having protection against infection or disease from the COVID-19 virus? If everything looks good in phase 2, we go to the final phase. And this is when we enroll thousands of study participants, very large trials. And basically we're asking one last question, and that is, does the vaccine protect against disease? Do we stop death, hospitalizations, severe COVID, moderate COVID, mild COVID? And again, because we're enrolling thousands of people now rather than tens or hundreds, we might also pick up on the possibility of unusual or rare side effects or safety concerns. And I can tell you that in the 2 vaccines that are now available for communities, the safety profile was outstanding, and we did not pick up any serious concerns in the very large phase 3 trials. And I'll say more about that. So at the end of phase 3, if the vaccine is safe and effective, if the FDA and the expert independent panel, who are not from the companies, but are independent academics, government officials, scientists, they will advise the FDA that they either believe or don't believe that the benefits of this vaccine outweigh the risks of this vaccine, and that it's reasonable to provide, in this case, the emergency use authorization that the vaccines are getting. And eventually, the companies will go back to the FDA and apply for full approval and licensure as they complete their packages that are required by the FDA to have that. And just a quick mention that there's something we call phase 4. So after treatment is available to the public, for instance, now, studies continue. We're still learning. The vaccines now have been administered to tens of millions of people in the US. Now probably between 25 and 30 million Americans have received the vaccine. And obviously we have a chance to learn a lot more. And again, I'm very happy to say that the safety profile continues to look outstanding, even with rolling out to millions and millions of people. The FDA, the CDC have systems in place to identify adverse events after a vaccine receives its EUA or full approval. So I think another really important issue has to do with the speed that we've all observed. It's pretty amazing. The genetic sequence of the coronavirus causes COVID-19 was published on January 10th. And within about 2 months, an RNA vaccine trial was started, the phase 1 trial. And then about 10 months later, both Pfizer and Moderna applied to the FDA for their emergency use authorization, and they were granted that on December 12th and December 18th. So we've had these vaccines now for a little under 2 months available to the public outside of clinical trials. Well, then that's pretty amazing, 10 months to having a package to submit to the FDA. How can that be? Because I think we've all heard, in general, vaccines take years and years, sometimes decades. Well, here's how it was done. First of all, because we were and we are in an international public health emergency, there has been intense effort by all sectors, government, academia, researchers and scientists like myself, the companies, the funders, community-based organizations, educators. Everyone has worked really, really hard because there's so many people becoming very ill, so many deaths, particularly in the elderly, those with chronic conditions. You know, the people most vulnerable, minority communities, those most heavily affected by COVID-19. Because of this emergency situation, there was intense effort. So that's part of how the speed was achieved. Researchers also used existing clinical trials networks to begin conducting the vaccine trials. So we had a lot of US government funded, for example, AIDS research networks and other infectious disease research networks, one of which we're a part of. Those were all sort of deputized to become COVID-19 vaccine research networks, research programs. And that was a key factor. In addition, the companies started making large supplies of the vaccine even before they knew that the vaccine was going to be shown to be safe and effective. And in that way, once the approval came from the FDA, as you saw, vaccine could immediately be rolled out within days, and we could start vaccinating the public. In addition, the messenger RNA platform that these first 2 vaccines utilize is very fast. It's easier to produce. It's entirely in the test tube. There's no cell culture, no eggs like many flu vaccines, hen's eggs. It's made in a test tube in a laboratory, and it can be done very quickly relative to many of the other older techniques. And finally, the US government, FDA and CDC have prioritized and streamlined the review process given the public health emergency. So those are all the ways that speed was achieved. And I think most importantly is to say what did not happen. What did not happen was that no corners were cut on safety evaluations. I've been doing vaccine clinical trials for 30 years. And I can tell you, we did these trials exactly the same way we do all of our vaccine clinical trials for the safety assessment. The most important thing is to be sure that these vaccines are safe for the public, and they are. So here's a quick sketch of the vaccines that are either already approved with an EUA or for Johnson & Johnson were just submitted yesterday. So the approved ones, Moderna and Pfizer, again, these are the RNA, the messenger, they're 95% effective. This Johnson & Johnson is, again, the recombinant adenovirus, the harmless common cold virus. It can't even multiply in the body. Instead of delivering the RNA, it delivers DNA, and it provides protection to 2/3 of people. And importantly, it's a single shot. So you can get 2/3 of people protected with a single shot. And that's really important. And again, I think I should sort of stage or set our expectations. 95% protection is really grand slam home run. We weren't expecting that by any means. The FDA will license any COVID vaccine that's 50% effective or higher. I heard Dr. Fauci say for these RNA vaccines, he would have been happy with 70% protection. So it really was a very wonderful and happy surprise that they were 95% protective, this new platform, this RNA. The adenovirus, it's obviously with a single shot, highly attractive. Also, it has simpler refrigerator storage, and it's 2/3 of people get protection from it. So again, an effective vaccine, and the FDA will be reviewing these data carefully this month. We expect very soon another adenovirus vector, very similar to the Johnson & Johnson, the AstraZeneca, to file for their US authorization later this month, I believe. And NYU participated in the US trial. We stopped enrolling about 3 weeks ago at our 5 clinics around New York City. I'm very proud to say that NYU enrolled over 900 participants. We had great diversity at our sites that were specifically selected for the diversity that they could provide. It's so important that we include diverse populations, communities in the trials. African Americans, Hispanics, Indigenous Americans, ethnic and racial minorities, older adults, both genders. And why is it so important? Because when we have a vaccine that is available with an authorization or an approval, we need to be able to go when we educate, like all of you will as community health workers, and say to those minority communities, yes, the Moderna vaccine, the Pfizer vaccine, they were tested in communities of people that look like you, communities that included people of your racial and ethnic origin. And they were equally effective in minorities. They were equally safe in people from your community. That's absolutely critical. And I'm able to say that with confidence because we did enroll those minorities in our clinical trials. So the AstraZeneca in overseas trials has, again, maybe a little lower than the RNA vaccines, but it looks like it's a protective vaccine. We'll see how high it is in the US trial that we participated in. We don't have those data yet. And then the last two that should come subsequently are Novavax and Sanofi, and these are protein vaccines. The ones that I mentioned are kind of like the flu vaccine. Just in the last week, some data from overseas again in Britain, that this vaccine was about 90% protective. So that's really good news that we have another vaccine with very high protection, close to the RNA vaccines. So these are the 5 leaders that we have for our RNA vaccines, or for our COVID-19 vaccines. And just to say a bit more about the 2 that have received their approvals, emergency use authorizations, Moderna and Pfizer. Again, these are both the RNA vaccines, the first 2 that made it through their human testing. The Moderna study enrolled 30,000 participants in the US. The Pfizer trial, which we participated in, enrolled 43,000 participants in multiple countries. And you can see that we had racial and ethnic diversity, 9% African Americans, 10% African Americans, nearly 30% Hispanic Latino here, 20% Hispanic Latino. So over, if you add up African American, Black, American Indian, Indigenous peoples, Hispanics, you're in the range of 30 to 40% in these trials. And that's really, really quite good compared to what we normally do. And it's so important because, again, these are the communities most affected by COVID-19. We had good gender diversity. We had 25% older adults in Moderna, 21% in Pfizer. So good representation in older adults who, again, are most heavily affected by COVID-19. And then we had people with chronic conditions in the trials as well, 20 to 25%. And important to say, for all of these demographic groups and all of these health conditions, the vaccines were shown in these trials to be highly effective and very, very safe. So just to underscore a little bit what I hinted at earlier, that the vaccines are safe and they are tolerable. There are expected vaccine reactions. These are not safety considerations. These are the expected vaccine reactions, like a sore arm, maybe fatigue or headache or body aches. And again, these start within the first day of receiving the vaccine and they go away within a day or so. They're usually mild to moderate. Most people can continue to work. It's a little bit rare to not be able to work, although that does happen in a few people. But what I always say, as I said before to my patients, is this is probably a good thing. It means your body is recognizing the vaccine and you're getting a response. And the other thing I like to say is, if you think that you're obtaining 95% protection against COVID disease for a day or so of arm soreness or mild fatigue, for example, that's pretty good. And in general, these things will occur. The sore arms maybe in 50–60% of people, and these others, fatigue, headache, body aches, not as often as that, more like 15–20%, a little bit higher with the second vaccine with the RNAs. So that's something for you to know in your education sessions, that we do see a few more reactions in the with the second vaccine than the first. Safety is the top priority, and again, it's FDA that provides the authorization, and then afterwards, the phase 4 studies that I mentioned, CDC and FDA continue to monitor for safety. What are we still learning about these vaccines that already have their emergency use authorizations from FDA? Well, we know they prevent COVID-19 disease. We still need to learn if they can prevent asymptomatic infection, and that information is pending. We will learn that. The data are being compiled and collected. That's important because most important, prevent the disease and the death. But we also want to stop people from asymptomatic infection with vaccines. CDC has said that up to half of infections may be asymptomatic, and we know that's more often in younger people. And we also know that there can be transmission to others, perhaps vulnerable older adults or those with cancer or HIV who may not respond as well to vaccines. So really important question still to be answered. We also want to know how long the efficacy, the protection will last. So far, we have the early follow-up, several months, but we don't have 1 year, 2 year. All of these trials will last 2 years. And then finally, these studies are ongoing, studies in children, in pregnant women, or in those with weak immune systems, like transplant patients, or those on strong immunosuppressives for rheumatoid arthritis or inflammatory bowel disease, for example. These studies are being done now. These types of people were not included in the original clinical trials. So with the 2 emergency use authorized vaccines, can pregnant or breastfeeding women receive them? Well, they were not included in the trials, so we don't have the evidence for that, but it's thought to be reasonable to consider. I feel that the balance of potential benefit to potential risk, which is what we have to look at when we don't have evidence from the trials, for someone who's pregnant or breastfeeding and perhaps is getting exposed potentially, that it is a very reasonable thing to do. These vaccines are, in my expert opinion, likely to be very safe in pregnant and breastfeeding people. What about immunocompromised? Same sort of answer. They weren't studied, so we don't have evidence. So then it comes down to what are the potential risks, the potential benefits, what is the expert opinion? And again, it's something that's reasonable to consider. I don't think there's going to be a safety issue with these RNA vaccines. They're very, very safe. They may not respond as well, but not unreasonable for these people to also receive the vaccine. And then what about severe allergy? Here, the answer is sort of, it depends. It could be that some people that have a known anaphylaxis type allergy, the most severe kind, to a component of the vaccine, those people definitely should not get the vaccine. People that have a severe allergy to the first dose should not get the second dose. There is partial protection from a single dose, so that's good news there. But people with mild allergies are able to safely receive the vaccines, and this can be discussed with their doctors. I think it's important to acknowledge that we have diversity in the scientists that are advancing these vaccines. Kizzmekia Corbett is at NIH. She's from North Carolina, from a very large family there. She became impassioned about science as a college student, began working at NIH, and she now is leading the team working on COVID vaccines at NIH, an example of wonderful success and inclusiveness amongst our scientists. Similarly, the two scientists that lead the Pfizer vaccine effort at BioNTech, the company that actually developed the vaccine and then partnered with Pfizer for its manufacturing capabilities. But these two, Dr. Torisi and Sahin, are of Turkish origin and are minorities who've been very, very important in the COVID-19 vaccine effort. And I can tell you, if you could see pictures of my staff, that we look like this, and it's so important. And I know it's important in community health workers as well. We need to have people that look like the people we're hoping to educate and engage and gain trust and eventually invite them to receive the vaccines. So important that we are from those communities in our teams that go out to work with them. As you know, we've had a first wave in New York City. We went down in the summer and now we've crept up. In the last week or two, it started to go down a bit. So that's great news. This is not from the vaccine. There's not enough vaccine that's rolled out yet. This is because of the old-fashioned mask wearing, social distancing, keeping gatherings to small groups, testing, quarantine and isolation when indicated. So those continue to be very, very important. But here's what's going to happen as we roll out the vaccines more and more. 3 examples from history: the diphtheria vaccine, the polio vaccine, the measles vaccine. And you can see when the vaccine rolled out, these diseases largely went away. And for many of us in developed countries are now of historical interest. They're not seen. One exception, as you know well, from 2019 was our measles outbreak, where we had outbreaks of vaccine hesitancy in certain minority populations, ethnic populations. And it shows what can happen if we don't continue to vaccinate. That thing I said at the beginning, as long as there's disease anywhere, virus anywhere in the world, we are at risk here. So my last slide or two, I'm going to close now, is just to say that while the vaccines provide protection, they're not perfect. And so we've got to continue to wear our masks, wash our hands, do our social distancing. And, you know, we still are going to be wearing masks for the rest of this year and doing all those other things for the reasons that I just stated. And finally, so important to educate communities and to educate the educators. So I'm so glad that all of you are here on this call right now. And I see 311 participants right now. And when we think about vaccine willingness, it falls on way over here. There's a lot of demand in many communities now. Then there's sort of, well, I'm not totally sure. I've got some questions. Maybe I need to wait and see. I want more information, sort of a passive approach. And then I think much less common are the situations of a definite refusal. There's no way. I think that is a minority. So we are able to make a difference with education. It has to do with building trust, empowering healthcare personnel, and engaging our communities and individuals. This is something from the NYU website. I took the vaccine. I recommend it to all my family. I'm so happy that this weekend my 88-year-old mother out in Colorado will finally get her first dose of one of the RNA vaccines. And really important, I hope that you will choose to get vaccinated yourself, that you will start conversations, not only in your life, your personal family, friends, but also in your work as community health workers, that you engage in effective conversations, that you become educated so you can answer questions. And we know from many years of research in vaccine hesitancy, the most important thing in the decision by one of our clients or patients to take a vaccine is a strong recommendation from their physician, their nurse, their community health worker. So start from empathy and understanding. Assume that they want to be infected, but be ready for questions. Give a strong recommendation. address any misinformation, but don't linger, don't repeat myths. Listen to and respond to their questions. Explain the expected vaccine reactions. Again, not a safety concern. And in a way, these are a good thing. Your body's reacting as it should, and they're mild and they go away in a day or so. And if they still decline, you know, it's okay. They're in control of their bodies, but encourage them to stay open and learn and say that you're always available. And this is what we hope for. Vaccine against smallpox, the great success, elimination from the world, eradication of the disease of smallpox. This is an old isolation hospital. It's on an island in the East River, Roosevelt Island. And thanks to the smallpox vaccine, this is now a decaying, crumbling wreck, a beautiful wreck, I like to say. And I hope that in a few years, our testing tents and so forth will also be, for COVID, will also become beautiful wrecks, that we won't need them anymore because the vaccine has led to control of COVID-19. And all of you as community health workers will make a big difference. And I hope that we at NYU and the Vaccine Center and all of the community outreach organizations that you know about can partner with you to beat the pandemic. And remember, vaccines don't save lives, vaccinations do. We've got to move the vaccine from the bottle to our clients, our patients. And with that, I will stop, and I thank you very much for your attention.
Thank you so much, Dr. Mulligan. I think we're just going to transition to the next speaker. That was an incredibly informative presentation, and you're getting a lot of comments, lots of questions in the chat that we'll be sure to address later. Ivette, did you want to introduce Dr. Ige? Or should we just move right into the second presentation?
I think we should just move on.
Okay, great. Thank you. Dr.
Thank
Ige,
you.
take it away.
Hi, everyone. And I want to start by saying thank you to Dr. Mulligan for a very detailed explanation of the process of the vaccine. So now I'm going to tell you about vaccine distribution and access. And this is from our work at the Department of Health. And for those of you who work with the community members, you know that people want simple messages in languages that they can understand and that resonates with their community. So I want to start by giving you some key messages that you can use in your community level engagement. One, we want to emphasize that the vaccines are safe and they are effective. Dr. Mulligan has done a great job of explaining to you why we have come to that conclusion. The second key message is that the vaccines are free for everyone. It is at no cost to the individual. If you have a health insurance, you may be asked for it, but there will be no copay. And in many cities run sites, you can access your vaccination without health insurance. COVID-19 vaccines are also available to people of all immigration statuses. And vaccination is not a public benefit under the public charge rule. So as you engage with members of the community, if they have concerns about cost, about if this is a public health charge or if this is restricted to US citizens, you can reassure them with these messages. And then finally, when people receive the vaccine, their privacy will be protected. So we want you to have this, at hand so that when questions come your way, you have these key messages to share. Next slide. So we want to give you some talking points and some pointers to how you can help communities access the COVID-19 vaccinations. Next slide. Let me start by giving you an update on where we are. This data is from yesterday when I sent in this presentation. So how many doses do we actually have in the city? The federal government is shipping vaccination to different states and different cities. This is what we have received so far, about 1.47 million doses of the vaccine have been delivered to date to New York City as at yesterday. And of this number of doses, 628,279 thousand doses have been used for first dose shots, and 155,458 people have already received their second dose. So when you compare this to the numbers from the clinical trials, you see that we have many, many more people who have now been vaccinated in New York City. They are fellow New Yorkers, they are friends, they are family, they are neighbors, they are colleagues. We know them, we know their names, we know where they live, and we have seen that the vaccines are safe and they are doing well. Next slide. So you may get asked, so how is it that some people are going first, or who gets to get the vaccine now, and why are some people not eligible? This is because eligibility is determined by the CDC. CDC provides guidance to states, and New York State determines what phase and who is eligible at each phase. So right now we have phase 1B and phase 1A eligibility. And in summary, that means people who are at risk of exposure due to the nature of their job, or people who are more likely to get severe illness if they become exposed to the virus. So you will see that reflected in these categories of people who get to go first. People who are 65 years and older, people who are at risk health workers, people who live or work in nursing homes or other group living facilities, and also frontline essential workers, first responders, teachers, daycare workers, transit workers, etc. And we have a complete list of who is eligible on our website that's shown there in the slide. So if you get questions about how do I know that I'm eligible, am I eligible, when is it my turn, you can check that website for a detailed list of who is eligible when. Next slide. So these are some steps for those who want to get vaccinated, those who have made a decision that, yes, I really want this vaccination. How do I go about it? First, you have to make sure you're eligible, and you can check up on that website and see, do I fall into any of the categories? If the answer is yes, you move on to step 2, which is to try and schedule an appointment. And now there are 2 ways to schedule an appointment. You can call through the 877 VAX for NYC number, or you can try and schedule your appointment through the online vaccine finder portal. If you happen to have some difficulty scheduling online or getting appointments to book, please know that it is because doses are limited. So you will only find appointments where doses are available. So if you're not able to find an appointment, that is because there are no doses available in that location at that time. And for the number, there may be a little wait time. And if you are told that you are not able to schedule an appointment, again, it is because doses are limited. So if you succeed in scheduling an appointment, the next step will be to fill out an NYS vaccine form. It is a self-attestation form that where you confirm and sign that you are truly eligible because you are in 1 or 2 or of the categories that have been stated. And once that form is completed, then you can march to your vaccination site and go get vaccinated. But remember, you have to bring proof of eligibility and also wear a face mask on the day of your appointment. So what is proof of eligibility? If you're eligible because of your age, you're 65 and older, please bring along something that indicates how old you are or when you were born. And that can be a passport, from your home country, or an ID NYC, or a birth certificate, something that indicates what age you are. And if you're eligible, based on your job, you'll need to bring something along that states that you work in that job, a pay stub, a letter from your employer, a work ID, anything to show that you are a frontline essential worker will be necessary. Now, the third proof of eligibility is related to residency. If you are going to a center that is operated by New York City, you need to show something that you are a New York City resident or that you work in New York City. If you're going to any other site, all you need to show is New York State resident or work in New York State. So I'll say that again. New York City run sites, you need New York City residents, or you must work in New York City. Every other site requires that you live or you work in New York State. And again, I emphasize, wear your face mask on the day of your appointment. People have been turned away and they were very upset. So please let your clients know, let your community residents know that they need to come to their appointment with a face mask, wearing a face mask. And then remember that second appointments should now be booked during your first visit. So when you go for your first shot, you should request for your second appointment to be made on site, and then make sure you get it. So those are the 5 steps you need to take to get vaccinated. Next slide. Now, this is what the Vaccine Finder website looks like. If you put in your address or your zip code into this finder, it will bring out a list of different vaccination sites. So the feedback that we have received is that people get confused. How is it that, I open this link, it shows me a different appointment interface, and then I open the second site and it shows something completely different. The reason for that is that there are several different types of providers that are providing vaccination to New Yorkers. Some sites are run by the city, some sites are run by the state, some sites are run by independent or private providers. So you will notice that there are different types of providers on that site. But one thing you need to know is that all sites only provide vaccination by appointment. So you need to book an appointment first. Do not walk in because generally you will be turned away. So let people know its vaccination is by appointment only. And again, I want to let you know that doses are really, really limited. Supply is limited at this time. So if people run into a scenario where they're not able to book the appointment, we want to please appeal to them to be patient and to check back again. Following day, we get supplies every day. So if you're not able to book appointments at your first try, please don't get discouraged. You can try again the next day and more doses may be available. Appointment availability is dependent on vaccine supply. Next slide. So these are the types of vaccination locations. All locations can be found on the vaccinefinder.nyc.gov, but there are other ways of navigating through the system. You may decide to go straight to the city-run site to make an appointment, and then you can go through the NYC Department of Health and Hygiene locations where all the city Department of Health sites will show up. And you can also go through the health and hospitals location through the link that I provided there. And you may decide to go straight to the NYS location like the Ivette Center and make an appointment. So I have put in the links to those different kinds of locations in the slide to make it easier for those who want to go to one or other of these locations. Next slide. I will also say that there are questions about, do I get to choose which vaccine I take? On the Vaccine Finder website, when you put in your address and you see the locations, each location will indicate what kind of vaccine they have. So if you want Moderna, you can choose to go to a site that provides Moderna vaccinations. And if you prefer to have Pfizer, then their sites will indicate what vaccine is available. But please know that both vaccines are effective. They have the same safety profile. They have very similar efficacy. They have very similar side effects. So whatever is available to you, I will encourage that you go for it. Both vaccines are more similar than different. There's subtle differences in terms of schedule of the second dose. Pfizer, you need to schedule your second appointment between 21 to 42 days. And for Moderna, you can schedule your second appointment between 28 to 42 days. But otherwise, the vaccines are pretty similar. You may also get questions about what transportation support is available for older New Yorkers. So for folks who are older, 65 years or older, and they don't have access to public or private transportation, and they need help getting to their vaccination appointment, the city is offering free transportation to and from city-run vaccine sites. So for those seniors who don't have access to ride or Medicaid-supported transportation, they may be able to access curb cab service or Hunter ambulance service. There is a contract with the state and it is free. They can call up either of these two services and let them know they're going for a vaccination at a site that is run by the city, and they will be provided transportation free. And then for customers who are deaf or hard of hearing, they can use whatever relay service they use currently, or call the 711 service relay, or visit the MTA Paratransit website for more information. Next slide. So there are a bunch of other questions that were sent to me ahead of time, and I will give you some answers now. I have mentioned, are walk-in appointments available, or do I need to schedule ahead of time? You need to schedule ahead of time. Walk-ins are not accepted at this time to ensure that there's social distancing and that people are not exposed and people don't have to wait for long times. Please schedule ahead of time. Language services that are available for making the appointments. The 877 VAX for NYC number is available in 180 languages. So you will be prompted to press 1 if you want other languages, and then you can indicate what language you want, and you'll be able to get support in another language. On the website as well, you can, if you want to book your appointment through the online Vaccine Finder website, there will be translations available in the top right-hand corner of that page, where you can choose what language you prefer, and you will see that translated for you. Will I be sent confirmation of my appointment by email or by text? Confirmation is sent by email for those who schedule their appointments online. And if you call to schedule your appointment, you will be asked what your preference is to confirm your appointment. Do I get to choose which vaccine I get? I answer that. We don't usually have 2 different vaccines in one location. So it's not likely that when you get to a site, you'll say, oh, can I have Pfizer today or can I have Moderna? Most sites will have just one type of vaccine, but you will see that information available on the Vaccine Finder site. It shows you what type of vaccine is available in each location. But again, I want to encourage you to whatever is available is good. They're safe, they're effective. Both Pfizer and Moderna have been authorized for use. So whichever is available, please go for it. How are homebound seniors and others able to access the vaccine? That is you know, a situation we're still developing plans for how we are going to address the situation. The mRNA vaccine is very difficult to transport around because of the storage and handling requirements. So it's a bit more difficult to move them from place to place. So unlike the COVID-19 test that we could move to different kinds of locations, we're not able to do that with vaccination. So for now, we don't have a process of getting vaccines to homebound seniors yet, but we're hoping that very soon we will have a solution for that. So that also applies to sending out mobile vaccination vans because of the storage and the handling requirement for these vaccines. It's a little bit challenging to move them about. Can your employer make it required for you to get the vaccine? At this time, the state is not making it mandatory for anyone to get vaccinated. Vaccine is a personal decision, and employers, we don't believe right now that private employers can make the vaccines mandatory, and that is because we don't have enough doses for everyone yet. It's going to be a while before we can get vaccines to everyone. But from the state, from the city, from the Department of Health, vaccines are not mandatory to anyone. How do we know that places providing vaccines are storing and handling them safely? There are very, very detailed requirements that are followed to make sure that vaccines are safe. In each site, there is a designated person who's responsible for checking the temperature of the vaccine and logging it several times a day to be sure that the temperature and all the other requirements are adhered to in very, very, very detailed ways. So we are all of the providers who are giving out vaccinations are pre-registered, and they have protocols for how they must maintain and store the vaccine so that it's safe for the clients. Next slide. Next slide. So we want to make sure that those of you who are on the ground working with the communities, that are community health workers, have access to clear, simple, science-based information that you can share with your communities. And these are some locations where you can get up-to-date information about the vaccine, about eligibility, about what number of doses are available, what has been given out, what is pending. There's social media kits. If you get vaccinated, we want you to post it on social media. I got my shot, NYC, vaccine for all, NYC hashtag. And this is to encourage those who are still not very comfortable with the vaccine. The more we see people around us, the more we see our friends, the more we see people we know get vaccinated and do well, the more confident we become. So we have flyers, we have information for older New Yorkers in large print, so it's easier for them to read. We have frequently asked questions. We have palm cards that you can share. And we also have a patient navigator checklist for those who want to help community members book appointments or navigate services. So these are some resources that are available on the website that you can check up every now and again and refer to as needed. Next slide. And that's it.
Thank you so much, Dr. Ige, for that wonderful presentation. It was so informative. So we will now move on to the Q&A. I just want to remind everybody that everyone is muted. Please only use the Q&A function for questions. We will have time to answer as many questions as we can. The chat box is open for comments and sharing resources. The slides and recordings will be made available at a later date. And please be sure to fill out our evaluation questions at the end. So let's begin. So Dr. Ige, one of the questions that we have, community-based organizations are asking to become vaccine centers. The rationale is that they are trusted community establishments with many years track records providing services to the community. Could this help address the long-standing lack of trust of the medical care system? When will CBOs have access to the vaccine and be able to distribute it to their communities?
Yes, so at this time, because doses are still limited, only a few places have vaccines right now. There's partnership with FQHCs and their partnership with other private providers where vaccinations are going on. If you go to the website, you will see around 180 providers citywide who have registered. Not everyone will have doses right now, again, just because the supplies are limited. But as supplies become more and more available, our hope is to expand partnerships to community vaccination sites. It will be important for any CBO that is interested in becoming a site to register with the city immunization registry to be a provider ahead of time. So, but we hope that as doses become more available, there will be more locations across the city providing vaccinations.
Thank you. And this is a question for Dr. Mulligan. Do vaccines protect against the newer strains that we are beginning to see? From what we are hearing, that's not the case. And if so, how can we help the community understand that?
I think you're on mute.
Thank you. Sorry about that. This is very much in the news. We're all hearing about these variant viruses. So important to realize that's normal behavior for an RNA virus, these types of viruses. They mutate all the time. I think you know that's true for flu. It's also true for HIV, and it's certainly true now, we know very clearly, for the coronaviruses like the COVID-19 virus. The vaccines appear to protect against almost all of them. The UK variant, the vaccines seem to protect against. The one where there is some brand new information in the last week or so that there's probably partial protection, but not the full protection, is the South African variant. So not surprisingly, we're starting to see suggestions with clinical trials that there may be some loss in protection against some of these variants. So far, that's the only one that I'm aware of. Now, the question was, will vaccines protect, or can they? And the answer to that is yes. Remember that every year we take the flu shot and it gets tweaked a little bit to match the currently circulating strains. And so that kind of thing may be what we have to do while we're fighting this virus and trying to build herd immunity. So already, in fact, we've been asked if we wanted to participate in one clinical trial of an updated variant virus vaccine. So already Moderna and I'm sure Pfizer are working, and I know some of the others are working on these. No doubt they're all working on them. And for the RNA vaccines, it's a relatively simple thing for them to sort of update their vaccine to match the currently circulating strains. We've had a year of virus circulation without any vaccines. My hope is that we become more efficient with our implementation of vaccination, that we have more and more supply, new vaccines coming online, and that during this year we can slow down transmission. Right now there's a lot of transmission, a lot more chance for the mutations to occur and to spread if they provide some advantage to the virus. That's how they get into the pool of circulating viruses. They somehow help the virus spread better, for example. So yes, we can fight back against these. The current vaccines protect against almost all of them, but I think that we're beginning to learn that at least one, the South African, there's some reduced protection, but we can fight back by updating our vaccines.
Thank you, Dr. Mulligan. And a question for Dr. Ige. So are vaccines being scheduled for homeless clients at provider sites such as shelters or safe havens? The NYC website says homeless shelter staff/residents are eligible, but the NYC vaccine pod does not have homeless shelters as one of the eligibility to check off. How can they get vaccinated?
So right now, the vaccination opportunities are limited to the centers that are on the website. We are exploring a number of options to make access easier for folks around the city. You may have heard that there's some NITA developments where vaccination is happening. Again, because doses are limited, we're only able to do 3 developments at a time, and where the seniors there can be reached and they will bring them out. We're also exploring a pilot for how we can use CBOs as referral, identifying residents who are eligible and then linking them to the vaccination site. But for now, we're still limited to a number of locations where doses are available, and then the online or phone scheduling to get people vaccinated.
Thank you. And for Dr. Mulligan, I know there's been, I guess, talk about if you had COVID in the past, why should we still get the vaccine? Could you tell us a little bit more about that?
Yes, thank you.
Why it's
That's
important? Mhm.
yeah, important question. It is recommended that if people who've had it before would like to get the vaccine, they get it. And I think it's a good idea. It's safe. We had people that had had it before in the clinical trials. We didn't see any problems. Here's why it's recommended. One is what's called waning immunity. So after natural infection, there appears to be a period of 1, 2, 3 months where reinfection is less common or uncommon or rare. After that, as we get further out and the immune system wanes or diminishes the strength of the response against a virus that challenges it, there is the opportunity for reinfection, and we know that can happen. Also, vaccination is safe in people that have had COVID before, and the response, the antibody response from the vaccine is actually much stronger than the antibody response from natural infection. And so I think you'll have better protection from the vaccine than you will have from natural infection. It's kind of backwards. A lot of times we think of that the other way, but this is a tricky virus. It probably weakens the response against it as it occurs through interfering with things like interferon. But in any event, yes, it's recommended. I think it makes sense. Probably in the first, certainly don't get vaccinated during an acute infection. That's actually against the recommendations. Wait until you're fully recovered. And I usually tell people it makes sense to wait a month or two, you know, let your immune system sort of get back to normal and then come in with the vaccine. The other thing that is interesting, and we now have some data from my lab, it could be that in people that have had COVID before, they only need 1 shot, because there it's acting like a booster. The original infection is sort of acting like the first shot. We don't know that yet, so it's not currently in the guidelines, but I just think it's something to stay tuned on. And that could be something that we see more discussion of in the future.
Wow, that's very good information. And then following up on that, what, once you take both doses or even the first dose, are there certain medications that you should not take during, like, are there any, I guess, research showing that, for example, you can't take Motrin or it will reduce its effectiveness?
Yeah, we know from the clinical trials that if someone takes their vaccine and then they start to get one of those expected vaccine reactions I talked about, like the sore arm, the headache, the chills, body aches, it's fine to take Motrin or Tylenol. And we encourage people to know that they can do that if they want to. We don't recommend that you take it as a prevention, that is before you have any sore arm. You may not need it. And that has not been studied. But in the trials, we did allow people to take it if they got a symptom that they wanted to treat with Motrin or Tylenol or something similar. And that was perfectly fine. It didn't do any harm. The only other thing is it's recommended not to have another vaccine within a couple of weeks of these two vaccines. So if you were going to get, for example, your shingles vaccine, it'd be better to maybe, my personal recommendation would get the COVID vaccine first because we're in a pandemic, and then get the shingles vaccine. But everybody over 50 should get the new shingles vaccine. It's a wonderful vaccine.
Thank you. Thank you. And this is for Dr. Ige. So a lot of, you had a slide talking about the different websites and what we can do to access, to make an appointment. Could you just reiterate, there's a lot of people talking about how hard it is to make an appointment and what should they do, I guess, like the first few steps.
Right.
Like what should they try first and then second? Yeah.
Yes, because I work with the Department of Health, I'll say try the Department of Health sites first. There are 15 vaccination hubs that have the capacity to take thousands of patients a day. So some can take up to 2,000 to 5,000 people a day, and some run 24 hours. So the Department of Health website, you can try that first and see if vaccines are available. If there's no availability, you will see in red on top of the page that there are no availability for now. You may not find vaccines in the sites that you prefer. So that's possible. But the biggest limitation is that the number of doses available are very limited. So that impacts what appointments are open. So if you see that there are no appointments open, it's because we've run out of supply. And once new supplies come in, then the appointments open up again. So yeah, it's very frustrating for people, but that's why we want you to have this information. So if you go to the website and you don't see any appointments, you know why, and then you know to check back again. So, but doses.
Yeah, it seems like to be the main problem.
Right, that is the main problem.
And well, following with that information, are you guys tracking like the types of factors that are, okay, I'll say it differently. Is there a problem around the equity in distribution across demographics, specifically in New York, or are there disparities based on race, class, sexual orientation, like the LGBTQAI or other vulnerable populations?
Right. As you all know, New York is a city of neighborhoods. A lot of inequities tend to cluster in neighborhoods. So we have done some work around identifying priority neighborhoods. If you follow the mayor, there was a press release on January 31st identifying what the priority neighborhoods are across the city. These are neighborhoods that have been most impacted by COVID, and that are also neighborhoods that have higher social burdens and other inequities. And vaccination sites have been prioritized for these locations. You may also know that there's a center that's just opened at Yankee Stadium this week. So locations in priority neighborhoods is one way we're trying to address that to make sure there's access. But we've also noticed that in many places, even when there is a vaccination site in East Harlem or Central Harlem or in South Bronx, many residents from those neighborhoods are not showing up for the vaccines. So we're also doing a lot to build trust and build confidence in the vaccine in those neighborhoods. So we have community conversations, we have educational events like this to use trusted voices, trusted messengers to get information out to the community that the vaccines are safe, they're effective, they're for all New Yorkers. It's not just for some racial or ethnic groups, it's for everyone. And to give people information that they need to be able to make an informed decision. So addressing the demand and the supply end of things, those are the two ways we're trying to make sure that these vaccines are equitable for all New Yorkers.
Thank you for addressing that. And I want to go back to Dr. Mulligan. We have a question about the different, you had a slide about the different vaccines that are coming up, and one of them was Johnson & Johnson. So one of the questions asks, why would anyone trust Johnson & Johnson after being told that their baby powder causes cancer? So it seems like there's some mistrust by them,
Sure.
Johnson & Johnson.
Yes, and I understand that. One of the beautiful things about the CoVPN, COVID Prevention Network, which is a government program for testing all of these vaccines, is that the clinical trials are independently monitored by a safety board that is totally independent of Johnson & Johnson. So their clinical trial was conducted within the US. And this is the single dose vaccine. And they had international sites as well, but the trial was overseen by an independent body of experts who are not from Johnson & Johnson, who are, as I said earlier, academic scientists, experts, and that group is the one that has monitored that trial. And now what happens, Johnson & Johnson just doesn't get to decide to go use their vaccine. Now they, as we've heard, they have applied to the US government to see if they can get permission to use it in the public, to have it become our third EUA vaccine. And so what's happening is they submitted a package of information yesterday. What I'm trying to say is that it's taken out of the hands of Johnson & Johnson. They may have produced the vaccine, but all of the testing was done within this government emergency response program, and the review and either rejection or acceptance to become our third EUA vaccine will be by an independent body and by the FDA. And the company doesn't get to decide those things. So they put their package of data together. It was submitted yesterday. The FDA and their independent panel of experts will go over the package carefully for the next, I think, 2-3 weeks. And then they'll have a public hearing. It's all day long. It's open to the public. You can watch it. I watched all day long for both Pfizer and Moderna. Any of you want to watch for J&J, you can. And you can decide for yourself if you think it's a fair and open process. It's the beauty of being here, of living in a country where we have these free, open processes.
And where can they find that link?
The FDA will post that link a week or two beforehand. Manor is on the call with me, so I'll make sure that once that becomes available, it's not yet, that we can provide that for people, because it is actually very interesting. It's live stream video all day long.
That's awesome. And I guess following up with that, they are doing the one dose. What's the difference between all the different vaccines? And is there one that should be maybe preferred over the other one, depending on the efficacy?
Yeah. So right now we have 2 that are available for the
Mhm.
communities that everyone here is serving. And that's Pfizer and Moderna. And their efficacy is the same, 95%. Their side effects are the same. Dr. Ige said that. I agree completely. What I always tell people is don't try and pick and choose, take whatever you can get. It's more likely to be difficult to find, and you probably won't get to pick and choose. My mother is 88, I mentioned, in Colorado. She was disappointed because in our research clinic, we worked on Pfizer, not on Moderna. And she at first heard that she was going to have to get the Moderna vaccine, and she wanted to get the one I worked on, her son. But she's now happy because she found out this Saturday when she goes, she is going to get the Pfizer.
Oh,
So
wow.
she's happy now.
Surprise.
But anyway, yeah. Anyway, take what you can get, and then the thing about Johnson and Johnson, the one dose as opposed to two, is it's a practical, real world consideration. It's a lot easier to vaccinate millions of people if they only have to show up once. So although it doesn't get you as much protection, it's not 95 with the RNA, I said 66.
Yeah.
That's still plenty of protection. It'll make a big difference. Again, I think compared, we always say some protection is better than no protection. So again, once those become available, if they do, whatever you can get, I would recommend taking. And it may well be that we're all going to end up getting boosters if there's some variant that we're needing to be sure we're protected against. But for now, let's go one step at a time. I recommend to take what you can get.
Awesome. Thank you. Thank you. And for Dr. Ige, we have some questions about eligibility. I know that we can go on the site. And one of the questions was, are food pantry workers and social workers considered essential? And are they eligible, as well as employees working at a bar? Do they qualify as restaurant employees?
Employees working at a bar, yes. Social workers, not yet. So for the current eligibility, social workers are not listed just yet.
And if I'm not mistaken, TLC drivers are now.
Yeah.
It's available for them too. Okay. Let me see. What other questions? So this is for Dr. Mulligan. One of the questions that we have is, why are COVID-19 vaccine side effects, or it seems to be more prone for the second dose versus the first dose?
Yeah, that is true, Yvette, for the RNA vaccines. For some of the others, like the AstraZeneca, which is a 2-dose adenovirus, it's similar to the Johnson and Johnson. The reactions are a little stronger with the first dose, not the second. So it depends which one, but the ones that we now have available for the public are the RNA vaccines. And the answer is, we don't know. We have made that observation, but we don't really understand why that is. It could be that some of the ingredients are triggering a response with the first dose in the body, and the body sort of remembers, and then you get the second bit, and it sort of triggers it up again. But that's just me speculating, and I think it's something we may learn eventually, and maybe then they could, in the future, modify the second dose so that you avoid that, that thing from happening. But again, I remember the word puzzle at the beginning, and safety and side effects were the biggest words. And I think for all of our community health workers to remember, these are safe, and the side effects, what I call the expected vaccine reactions, those are not safety issues. It's more just tolerability. And it's in fact a good thing. And we really need to work on the education for that people know that it's okay to have a bit of a sore arm, to feel a little off. And another way to, I think, to talk to people in communities or to individuals is to say that, and it's not a bad trade-off in order to get 95% protection against COVID-19, to have, a half a day or a day of not, feeling just a little bit off.
Thank you. Thank you. And Well, we're almost going towards the end. Just looking up other questions. For Dr. Ige, I know you did talk about this in the end, but just wanted to ask this question. Are there public education campaigns or resources that are being made available to local social service providers to help educate their communities, for example, for the vaccine, and how can we access those?
Yes, so we have a standing training of trainers event every Tuesday and Thursday, and I can share the flyer with you, so you can all have that. So it is targeted to community-based organization staff to train them on messaging and navigation of services. We also have a speakers bureau where you can invite a speaker from the Department of Health to come talk to your community or your organization to provide them more information around the vaccine. So we have the Vaccine 101 introduction to the COVID-19 vaccine series that speakers can come and provide to you. We also have community conversations. These are really targeted at addressing hesitancy, creating spaces, particularly for people of color who want to ask questions and get more information about how the vaccine work, how is it, you know, affects people of color and other concerns that they have about the vaccines. In addition to that, you may have seen it, multimedia, multi-channel media campaigns. We have videos, we have social media kits. Um, the full Vaccine 101 presentation is on video. We have COVID video. So several resources that organizations can use in supporting messaging to their communities.
Okay, and are they also available in different languages?
Yes.
Okay. And just to confirm, I know you said on your first slide, I believe, or the first few slides, it's free for anybody, correct? Like it doesn't matter if you're undocumented, you know, it's free. Okay.
Okay.
And let me see. For Dr. Mulligan, I know that there are time frames for each dose, for each vaccine. Is it recommended, or will it be an issue if it goes beyond the recommended days? And is it still effective?
It's not an issue, and it is still effective. I strongly believe in the clinical trials, we had windows from, like for Pfizer, where it's recommended to get the second dose 3 weeks later, so 21 days. We had a window from day 19 to 23. And we know if you're in that window, it's 95%. Going longer, I am very confident, very comfortable saying I don't think would be a problem if you had to delay. I had a phone call from one of our staff at NYU 2 days ago. She was upset because she was scheduled to get her second dose the next day, but now she had a cold or something. I could hear her kids in the background, and probably daycare, and hopefully not COVID. I told her, well, one, you can't go in and get your second dose because you have an illness, and we're not supposed to go into, when we have an illness, we need to get tested then during the pandemic. But I also told her, her big concern was that the vaccine wouldn't work if she didn't get it tomorrow. And I told her it's going to be absolutely fine. There's no problem waiting a few days. And actually, if anything, you get a better response with a slightly longer period. So no problem delaying it for a few days or even a week or two. But it's not the routine. You want the routine to be stuck to, but when you have to, it's going to be okay.
How does the vaccine affect pregnant mothers and breastfeeding babies? have there been any research regarding effects on fertility for women and men? That's a big thing. That I've been hearing actually that adolescents, they're like, no, they won't take it because it affects that. And is there sufficient research on COVID-19 vaccine and pregnant women?
Yvette, I'm sorry to interrupt. We're having trouble.
Hearing.
Nadia, I heard you well. Can you hear me well?
Yes, I can hear you fine, Mark. Yvette, do you want to try again? See if it's,
Yes, can you guys hear me
yes,
better?
it's
Yeah.
perfect now.
Okay, perfect, thanks. So the question was, how does the vaccine affect pregnant mothers and or breastfeeding mothers and babies? Has there been any research regarding effects on fertility for women and men? Which interestingly enough, I've heard teenagers talk about this. Is there sufficient research on COVID-19 vaccine and pregnant women? And are there any resources to learn more about this?
Yeah, those are great questions. So as far as resources, there are, and again, maybe this is something Manor can help me and we'll provide it. For example, the ACOG, American College of Obstetrics and Gynecology, has a resource and provides guidance. There's a CDC document on clinical guidance for use of the two RNA vaccines. The clinical trials that we did for Pfizer and Moderna enrolled a total of 75,000 people. And we did pregnancy tests on all of the women and they were excluded if they were pregnant. They were not allowed to be in the trial. However, during the trial, each of them, there were many women who became pregnant. We asked that that not be the case in the first few months around vaccination, but I can tell you this happens, as everyone knows. And those women who became pregnant, you know, at the time of vaccination or soon after or later, they're all being followed in the clinical trials. So we have that information that will become available. Thus far, nothing, no problems reported, and I don't really think there will be. The biggest concern about vaccines in pregnant women is we wouldn't give a live vaccine to a pregnant woman, like a live viral vaccine. This vaccine is an RNA vaccine. It's not a live virus. And I personally, my belief is that it will be fine. And I've recommended to several women that, like, we've had a lot of women call and ask, yeah, I'm a nurse. I'm getting exposed all the time. I'm pregnant. Can I take the vaccine? And then again, it's the answer about, we don't have the evidence yet. The studies are planned. They're going to do studies in pregnant women getting the vaccine during pregnancy. But for now, it's permissible, it's allowed. CDC, FDA have said that if a woman has some risk of getting infected, then it's not an unreasonable thing, given everything that we know, although we don't yet have the evidence. So I do feel that it can be discussed, or that women can just make up their own minds and go ahead and do it. They're empowered to do that. It is allowed. And I actually believe that it will be safe, but soon we'll know that with the clinical trial.
Awesome, thank you so much. And we have room for one more question, and I'll direct it to Dr. Ige. So what is the potential for mobile vaccination for street homeless individuals and on-site vaccination at large congregate shelters and supportive housing residents?
Right now, congregate settings and nursing homes are supposed to get their vaccines on site, and that is a contract that's been given to CVS and the large pharmacies to do. Again, the limitation why this has not happened everywhere is the number of doses, but that the plan is that congregate settings will receive their vaccination on site. It will be brought to them.
Okay, great, awesome. So I think that's all the time that we have. Thank you so much, Dr. Mulligan and Dr. Ige. It was so informative, incredible, and you can see all the comments that are just, you know, raving about how amazing the information is. So thank you to you both. And I'll leave it to Dina.
Hello, everyone. If you are joining us through Zoom, you should see a poll with 4 questions about the town hall pop up on your screen right about now. Please take the time to answer these questions. My name is Dina Pimenova. I am a project coordinator and I help run the NYU Langone Community Health Worker Research and Resource Center along with Amy Freeman, Sue Kaplan, Nadia Islam, and Sana Lim, all of whom are faculty in the Department of Population Health at NYU School of Medicine. On behalf of my colleagues, I want to extend our gratitude to Dr. Ige and Dr. Mulligan for taking the time to share their expertise and answer the questions that we all have encountered about the COVID-19 vaccines. I want to also thank Ivette Cabrera for doing such an exceptional job moderating today's Q&A. And this event would not have been possible without a number of people, Dr. Lorna Thorpe and Dr. Natasha Williams, who led the NYCHA Resident COVID Response Project, the NYU Langone Vaccine Center team, Manur Ali, Michelle Fang, and Juanita Erb, as well as our friends at the New York City Department of Health and Mental Hygiene, Liz Hamby, Kimberly Wright, our community service plan team, Sue Kaplan, Amy Freeman, Harmony Arcilla, Jennifer Norton, Bethany Springer, Bin Liu. And I want to give a huge shout out to the behind the scenes team, Dr. Amy Freeman and Harmony Arcilla, who have made sure that today's town hall ran seamlessly. And lastly, thank you to all of our attendees for sending in your many thoughtful questions to help us facilitate such a rich discussion, and also for all of the important work that you're doing to educate and take care of your patients, your clients, and community members during this extraordinarily difficult time. We have a long road ahead of us, but providing accurate information about COVID-19 and how to protect ourselves against it will be key. You are the trusted messengers for many, and we sincerely hope that following today's town hall, you are feeling more equipped to handle these discussions. We will be making the slides and recordings of today's town hall available soon, so please stay tuned for an email from me about those soon. And I see that the poll is up right now. Just please make sure to respond. And again, thank you all so very much. And take care.
I'm just going to take a brief screen privilege to give a double and huge thanks to Dina Pimenova and to Amy Freeman, who really very much drove this event along with the various collaborators that Dina highlighted. That really huge thanks to you, and again to our panelists. And to community health workers. You know, we are so inspired by what you do every day, and so anything that we can do to support that, we're very happy to do. Thank you, Dina.
Thank you.